A lot of people here today, wow. I didn't realize so many people crossing the river. I want to thank Jeff Onan for giving me a chance to speak here. Why are we talking about this today? The reason is it's practical. You see head trauma all the time. There's a lot of anecdotal evidence and myth surrounding head injury, and it's something you can take back to your shop and implement for any provider. So that's why we're talking about head injury myths. So this is where I work, again, across the river in Paterson, New Jersey. It's not too far without traffic, 20, 25 minutes. In traffic, like this morning, it was like an hour and a half. So we'll cover 3 quick myths, 10-minute talk. You can't cover a ton of things. And here's the myths, and you probably know some of these already, but I think it's worth reinforcing. So the first myth is anticoagulants are the highest risk medications for traumatic intracranial hemorrhage. I'll argue that they're not. It's probably antiplatelets, although there's a lack of evidence in that arena. Number 2, delayed bleeds are common in patients who have minor head injury on anticoagulants and deserve a period of observation in the hospital or repeat neuroimaging. I'll argue the opposite. And the third thing is, of course, we'll wrap up with the limitations of the Glasgow Coma Scale as a marker of the severity of head injury. So first myth, anticoagulants are the main player in terms of traumatic ICH, in terms of causing traumatic ICH in patients who have minor head injury. So let's look at this a little bit. So some data here from Nishijima and colleagues out in California. This was a prospective study over 1,000 patients with mostly minor head trauma. 3/4, or actually 4/5 of these patients had falls, and over 4/5 of these patients had normal mentation when they presented, and they were all on anticoagulants or antiplatelets, and they looked at the incidence of immediate intracranial hemorrhage and delayed intracranial hemorrhage in these patients. 3/4 of these patients were on warfarin, and 1/4 of these patients were on clopidogrel, and there was concomitant aspirin use amongst both groups. And what they find as far as immediate intracranial hemorrhage, here's the numbers. Now you're limited here, only about 70 of these patients had an immediate ICH, so small numbers. And all of these studies are small numbers. But out of these small numbers, over double the rate of ICH in patients on clopidogrel. I was taught the opposite a decade ago when I trained. I was taught worry about warfarin. No, worry about clopidogrel. They also looked at delayed ICH in patients, and we'll come to that a little bit later on the next myth. They looked at the same data set in a different study, in a different journal, trying to come up with predictors of immediate ICH in these minor head injury patients. Who could you predict would have an ICH? And the biggest predictor was actually vomiting, with a relative risk of over 3. The next biggest predictor was clopidogrel use, relative risk of 2.52. They also showed that none of these were good enough for excluding injury. There isn't a single thing in these patients, who were elderly patients with falls, that you could say, if absent, excluded a head injury, which means you have to use liberal imaging. What about aspirin? Same thing. Almost 1,000 patients, another prospective observational study. All of these patients were over the age of 55, blunt head trauma. Majority of them were falls, so elderly patients, and all of them were on one thinner, aspirin, clopidogrel. Not all of them on one thinner, but at least one thinner. Aspirin, clopidogrel, warfarin, a NOAC, or one of the new antiplatelet agents. Some of them were on 2. And so what did they find? The overall immediate ICH rate in these patients, 3.5%. A lot lower than I would have thought. I thought it'd be a bit higher. In patients on a thinner that are elderly, that hit their head. Overall, 3.5%. Which agent do you think had the highest immediate ICH range? Aspirin. Aspirin, about 4.3% of the patients on aspirin had an immediate ICH. Warfarin, 1.7%. Aspirin. 4/5 of those patients on aspirin were on a baby aspirin. Do you care for patients on a baby aspirin? Everyone's on baby aspirin, right? So my take home here is worry about the antiplatelets as much as you were taught to worry about the anticoagulants in minor head injury. Why did I show you a picture of an ambulance? Because where do we get the medication history from? We get it at the bedside, but we also get it from pre-hospital providers. And there's some data suggesting that we don't get that medication history from the pre-hospital providers. They'll tell you if patients are on anticoagulants. They may not tell you if they're on a baby aspirin. So you have to probe. That history is important. NOACs. I know you had a NOAC talk earlier in head injury. Just to mention, very limited data with NOACs in head injury. However, low immediate ICH rates. Right? In that 1,000 patient cohort I showed you, the small amount of patients on NOACs, it might have been 20 or 30, no bleeds. So probably less of a bleed rate as far as head injury with NOACs than antiplatelets and warfarin, but we need more data to actually show that. And the last thing is, we worry about thinners in minor head injury. Antiplatelets, anticoagulants, I told you to worry about both. Worry about antiplatelets more, but worry about everything your elderly patient is on. Because why did they fall in the first place? And a lot of the medications that they're on are loosely tied to falls and adverse drug reactions that may have led to the trauma in the first place. So not only should we be looking at their thinners, but we should be looking at everything they're on, and do they need to be on it? And was that the root cause of their sentinel event? So take home here, respect antiplatelets in minor head injury, probably more than you respect anticoagulants. Pay attention to pre-hospital meds, probe to make sure that patients are, if they're on antiplatelets or not, because you'll get the anticoagulant history right off the bat. And the third thing is pay attention to all the meds your patients are on in minor head trauma. Second myth, delayed bleeds. Probably, this is a pretty up-and-coming bunch practicing evidence-based medicine, so this may not be new to you, but delayed bleeds, the myth I'm going to try to disprove here is these patients need to be watched in the hospital and have repeat neuroimaging. I don't think they need either. Okay, it's patient to patient, it's case by case, but a general rule of thumb. So what's a delayed bleed? So a patient has a head injury, their initial CAT scan is negative, and then an interval period after that, we say out to 2 weeks, they have the development of an ICH on their CAT scan without trauma in the interim. That's a delayed bleed. You know how hard that definition is actually defined in the literature? Like every article on delayed bleed, they don't actually define what it is. You just kind of have to figure that out on your own. But that's what I think it is. And so delayed bleeds, if ICH in minor head injury is not common, and I showed you 3.5%, you could guess the delayed bleed rate is even lower. And so here's some data. So almost 900 patients, observational study just published in February, JAMA Surgery. About 350 of these patients were taking either anticoagulant or antiplatelet, so a good amount. And they followed these patients to 14 days. All these patients had an initial CAT scan that was negative. Okay? And they followed these patients. They either had repeat imaging or they were followed with a phone call. And what did they find? They found a total of 3 delayed bleeds. 1 in a warfarin patient, and 2 in patients not on anything, thinner-wise, right? 3. 0.3% for warfarin, 0.4% for those not on any thinner. Pretty low. That first Nishijima cohort study I showed you, delayed bleed rate for warfarin was 0.6%. Pretty low. They're uncommon. Super uncommon. Extremely uncommon. Very uncommon. How do you predict them? You can't. There's no predictor, and I'll show you that. Some more data showing the same thing. Systematic review, 7 studies, over 1,500 patients. Here they looked for a delayed bleed within 24 hours, because what do we do when we put people in the hospital looking for delayed bleed? We watch them for 24 hours, right? We don't watch them for 2 weeks or even 48 hours usually. 24 hours, sometimes 48 hours. So they looked at the delayed bleed rate in a day, almost 1,500 patients. The delayed ICH rate in these patients, all on warfarin, 0.6%. And of them, only 0.13% died or needed intervention. So bleed rates low, even lower that they're clinically significant. So what do you do with them, right? So the myth is you observe them and repeat neuroimaging, and sometimes you do have to do that, but I think general rule of thumb is these patients can probably go home. There's a nice best bets on this published in 2014, looked at a bunch of studies, and they support discharging these patients in this paper, and the things that they say are the following. Low incidence of delayed bleed. A lot of them happen past 24 hours, so even when you watch them, they could happen later, right up to 2 weeks. Admitting these patients hasn't improved their outcome because they don't have bad outcomes in general. And The bottom line is these patients need clear discharge instructions. They need to be stable patients who are watched and understand what to come back for. So I haven't helped you. I've said basically talk to these patients. If they're reliable, send them home and they follow up. So are there predictors of a delayed ICH? And the answer is I don't think so. I don't think so. A couple of papers I looked at, some predictors they mentioned, elderly age, concomitant antiplatelet use, history of diabetes and hypertension, but none of these have really been shown in good studies to be predictors of delayed ICH. One that we talk about is INR, right? But you tell me what INR you pull the trigger on. Who has to be watched? Is it 2.5, 3, 3.5, 4? There's no number in the literature. A lot of people say super therapeutic. If it's above 3, those patients should be watched. But a lot of the data on delayed ICH patients had mean INRs of 3.5, 3.8. So I don't know the INR number, but you can tell me after this lecture what your shops use. But that might be a predictor. I just don't have the number for you. Take home, delayed bleeds, uncommon. They occur past 24 hours, commonly. We need risk factors to identify who we need to watch. We don't have that yet. And I think observation and repeat neuroimaging across the board is unnecessary. I think you have to select certain patients to do that. Last myth, quick and easy, and we'll hopefully finish on time, is GCS. So why are we talking about GCS and the limitations of GCS? And you've heard this, right? If you're on FOAMed, if you're online. And we're talking about it because of this, right? Outdated dogma and rectal exams forever. That's why we're talking about GCS. And there's a lot of that in here. But we need to practice this, right? We're trauma centers. Yeah. So, the problems with GCS. Poor inter-rater. You score GCS, you score GCS, you score GCS, and we disagree 50% of the time. First problem. Hard to remember. All rules and scoring systems need to be easy to remember. We're emergency physicians. No one can remember the GCS, no matter what. Too many combinations, over 100 combinations for a Glasgow Coma scale. And the biggest thing is it accurate? So the GCS wasn't designed to be used the way we use it, right? It was an interval score. You come in with a head injury, your GCS is 14, and then in 6 hours it's 8, there's a problem. That's how we use it. But we don't use it that way, at least in emergency medicine. You come in and your GCS is 12 and I say you're sick, and you have a head injury. That's not true. I mean, you could be. You are until proven otherwise, but you could be intoxicated. You could be encephalopathic. You could be any number of things besides a head injury. And so is it accurate, predictive of the severity of head injury? And I think not, because of these reasons that we mentioned here. And these reasons, although we know intoxicated patients have a higher risk of head trauma, probably still, right? Their GCS could be 8 or 9 or 12. So what do? I haven't helped you again. Don't use it. Right? This is off short coat blot. What should you do? Maybe use the simplified motor scale or score. The most useful part of GCS is the motor score. The motor score. Predictive of head injury, a focal neurodeficit. Use that alone. Or just use your gestalt in your exam. How does the patient look neurologically? What's their appearance? What's their motor score? And use that, but don't use a single GCS. So in wrapping up, meds, worry about clopidogrel, aspirin, and the antiplatelets as much as any other thinner. Maybe worry less about the NOACs until we have better data. We need better data. Number 2, delayed bleeds are uncommon. We need better predictors for them. They don't need to be imaged again in 24 hours across the board. And number 3, move away from GCS, move towards using a full exam description of the patient. I thank you for your time. And are we taking questions?